Okay, this is a voiceover lecture on terminal illnesses, and we focus a lot on basically childhood cancers like neuroblastoma, leukemia, some of your lymphomas, non-Hodgkin's and Hodgkin's, um, those sorts of diagnoses. So not the most positive, but nonetheless, we will get through it. So I'm hoping that we can look at neuroblastoma and its effect on the child, discuss other types of cancers, looking at leukemia, lymphoma, and looking at the different types of lymphoma. Neuroblastoma. Neuroblastoma, if you take the word apart, you have neuro, which is something neurological, and oma is sort of a tumor. And so you have a tumor or a cancer that involves specialized nerve cells that are involved in the development of some type of nervous system and other tissues, typically surrounding tissues. Most children are diagnosed under the age of 5 years of age. Sorry, I just had someone knock at the door. So anyway, most children are diagnosed younger than 5 years of age, so they're typically younger. Most often, what's occurring is a tumor that sort of presents in the abdomen. Typically, one of the most common places is near the adrenal glands, and the adrenal glands maintain blood pressure, assist in how we respond to stress, right? Because the adrenal glands are actually producing adrenaline, okay? So that's going to affect blood pressure. That's going to affect, our fight or flight response. And so scientists believe that there's actual abnormal cell growth that occurs just during the normal, typical development of the adrenal glands. And so that may originate that neuroblastoma, primarily in the abdomen. Other cases, neuroblastoma can occur alongside the spinal cord, which is another quite common place, anywhere along the spinal cord, near the nerve tissue. So it could be in the spine, the neck, the chest, the abdomen, or even the pelvis. With a lot of cancers, not just neuroblastoma, but what's scary about cancer is the symptoms are very similar to that of typical childhood illnesses. So with neuroblastoma, you may have a loss of appetite, you may be tired, or your child may be tired. They may complain of pain in bones, they may have a swollen abdomen. And so I think what's significant about that is, remember, most children are diagnosed under the age of 5, and so they may not be able to tell you that they hurt in their bones, right? But they may be rubbing their leg, or they may be rubbing their tummy and saying, owie. They may be tired. They may not have an appetite. And so that's very similar to influenza. That's very similar to a cold, those kinds of things. And so making sure that the parents are following up with this, especially if these symptoms don't go away. High blood pressure, again, with those adrenal glands being affected, the child may have high blood pressure. If that tumor is closer to their trachea or alongside their trachea or by their lungs alongside their spinal cord, they could have difficulty with breathing and swallowing. Interesting, some people with neuroblastoma present with small blue-colored bumps in their skin, and that's actually the blue pieces are part of neuroblastoma or part of that tumor. And so that may be where those blue-colored bumps come from. And again, if that tumor is pressing on the spinal cord itself, depending on where their spinal cord or where at in that spinal cord it's affected, they could have lower extremity weakness or unsteadiness, those sorts of things. Typically, how they diagnose neuroblastoma is they do a variety of blood tests. Okay, so a lot of the symptoms, decreased appetite, pain, achiness, those sorts of things, they may just be looking for a typical infection, right? So they're going to do a blood test. They may do a urine test. They may do a bone marrow test. So if these symptoms are progressing and there's certain cues in the blood tests and urine tests to maybe suggest cancer, they may do a bone marrow test as well, because leukemia is a very common childhood cancer as well, and so they'd be looking at the bone marrow. Then they may do x-rays, CT scans, MRI scans to try and find the exact position of that neuroblastoma and to see if it's spread anywhere or how it is spread. And so this is known as staging, kind of staging if the tumor is localized or if it has spread. There's a staging system that's specific to the type of cancer you have. And so looking at the International Neuroblastoma Staging System, there is a pediatric cancer staging guideline, which I took this off of. It's a very long document, but it looks specifically at neuroblastoma. So with stage 1 means that there's a tumor that's just contained to one area of the body. Typically with stage 1, there's no evidence of it spreading, and they can remove mostly all of the tumor, and if not, there may be very small amounts of it left. When you look at stage 2, there may be 2A or 2B. And so with 2A, there's no significant symptoms. So when you think of appetite loss, when you think of the blue bumps in the skin, you think of weakness or limping or those kinds of things, difficulty breathing, they aren't having that symptom with 2A. However, with 2A, the tumor is still localized, but they still cannot completely remove that tumor. With 2B, again, it's still localized. However, there is some spreading to the lymph nodes that's typically on the same side as the tumor, so the ipsilateral side. Stage 3, cancer is spreading to surrounding organs and structures. And so with stage 3, the cancer has maybe spread not just to the surrounding lymph nodes, but maybe to the surrounding organs. It has not spread to the distant areas of the body yet. Okay. Stage 4, the cancer has spread to the distant lymph nodes. So if the tumor is on, in the chest cavity, sort of on the right side, of the spinal cord, and they're at stage 4 cancer, it's going to be spreading to the distant lymph nodes. So in their left groin, they may have swollen lymph nodes. Also, when they test bone marrow, it may be affecting their bone or bone marrow. And again, those other organs such as liver, skin, may be affected. So with stage 4, you may see those blue bumps in the skin. 4S is something unique just for children under the age of 1. Okay, so the S is just for children under the age of 1 year of age. Here the cancer, there is a localized cancer, again, so there's a tumor that's localized. However, it has spread to the liver, skin, and or bone marrow, but again, it's only for children under the age of 1. When you talk about cancer and the different terms, you'll hear the terms metastatic cancer, which means that it's spread, right? Sometimes the lingo is METs. So there's stage 4 cancer METs, meaning that they're stage 4 and it has spread to those distant organs and lymph nodes. Or there's stage 2 METs, which means that there is some metastases, perhaps of those nearby lymph nodes. When we hear recurrent cancer, it means that the cancer has been in remission. So maybe you want to call it cured, but then after so many years or after so long, that cancer has come back. And so they've had a remission, but now they have cancer again, so that would be recurrent. Neuroblastoma treatment is very dependent on the age of the child, and really with any childhood cancer, I'll talk about this later with some personal experience. It really is dependent on the age of the child, the size and position of the tumor, and how far that neuroblastoma has progressed. First and foremost, if the cancer has not spread to distant organs, distant lymph nodes, they may begin with surgery. Okay, by looking at surgery, they analyze that tumor. They depend on what kind of cancer it is. Is it a high-risk cancer, meaning that it's likely to spread? They may certainly try and get all of the tumor with the surgery. They may also do chemotherapy for some of those tumors that have spread or as categorized as high risk. Chemotherapy is where you basically there's many different types of chemotherapy drugs. This particular individual is receiving chemotherapy. She's hooked up to an IV. That IV is administering her chemotherapy drugs. Those chemotherapy drugs travel systemically throughout the body, through her bloodstream, and hopefully they're attacking those cancerous cells. Since it is systematic, chemotherapy, there's some awful symptoms that go and side effects, including hair loss, including decreased appetite, including nausea, vomiting, pain, fatigue, just some very, very, very significant side effects. There are some chemotherapy drugs that can be administered orally, some are IV, those sorts of things. So just know that chemotherapy typically is a systemic drug that's used systemically. Radiation can also be used. So maybe they remove part of the tumor, right? Part of the neuroblastoma. They may follow up with, if they didn't get it all, they may follow up with radiation to sort of obliterate what's left of that tumor. They may do a combination of surgery, chemotherapy, and radiation. So it just sort of depends on what that oncologist believes is the best course of treatment. Neuroblastoma, the prognosis is good. Children less than 12 to 18 months can get good risk tumors, which mean they're not at risk for spreading. They're just sort of a growth. So typically they can go in and remove those tumors, and they more than likely aren't going to be reoccurring. Chemotherapy is usually only needed if there's symptoms from the tumor. Again, with the fatigue, or again with the limping, or difficulty breathing, those sorts of things. And even some neuroblastoma that start out as small may disappear on their own. However, they may also develop into a ganglioneuroma, which can be very complicated. If you look at ganglio, it sort of means finger-like, and oma meaning tumor. And so, again, with the ganglioneuroma being close to the neurocells, you could have fingers wrapping around the spinal cord. And so when you go in to remove that, it can be a very, very, very delicate procedure. So neuroblastoma, even though some of them do disappear on their own, they do require careful monitoring. Most children under 12 months of age that are diagnosed with a neuroblastoma are cured. So that's good news. Brain tumors. The cause of brain tumors is unknown. They're believed to be either developmental, meaning as that brain is developing, something goes awry and just abnormal cells are produced. Or there could be something chromosomal, some sort of chromosomal genetic abnormality that contributes to a brain tumor. Signs and symptoms mimic many childhood diseases, such as a headache, vomiting, loss of coordination, strength. I would say just personal experience, there's been visual issues also with brain tumors. Since brain tumors are part of your neurological system, You may see an increase in reflex activity. So you may have somebody who starts developing the Babinski reflex, or somebody who starts having AT&R when developmentally they had already integrated that reflex. There may be changes in behavior. They may develop seizures, and they may have issues or disturbances within their heart rate, their respirations, blood pressure. Typically, they diagnose brain tumors with a CT scan and or MRI scan, so they're looking specifically at the head and looking at where that tumor's at. Typically, their first choice is to go in and remove that tumor in the brain, and typically they combine that with radiation. Unfortunately, with the brain being as sensitive as what it is to trauma, when you have surgeons that go into the brain, they're going to try and remove as much of that tumor as possible with the fewest short-term and or long-term effects. So again, with that tumor, it's going to be pressing on certain aspects of the brain, whether it be the motor cortex or whether it be the limbic system. So depending on where that tumor's at, could depend on kind of the symptoms that you're seeing. Unfortunately, when they go in and they remove that tumor, they may have to remove portions of the brain as well. And so when they do that, there may be long-term implications to movement. There may be ataxia, there may be spasticity, there may be hemiparesis, lack of range of motion, lack of body awareness on that side, lack of sensory on that side. So, or on the opposite side for that matter, of the brain. Very similar to that of somebody who's experienced a stroke in the right hemisphere, their left side is going to be affected. And so you'll see some of those negative effects possibly happening when they go in to remove the tumor. And those problems can occur after surgery. I have worked with some kids too who have had most of their tumor removed, and because of kind of the delicacies of the brain, they weren't able to remove all of it, and so they follow that up with radiation to try and radiate those specific areas they weren't able to get. After surgery, there obviously is a lot of swelling in the brain that occurs, and so I've had some kids who have had shunts to sort of relieve some of that pressure. I've had some kids who have had hemiparesis on one side of their body just because of the swelling that's occurred from post-surgery, and then as they heal and as that surgery naturally, or as that swelling naturally decreases, they do regain some of that motion. However, I worked with some kids who never regained that motion. And so, again, it's kind of a combination of how much of the tumor do they take with the fewest and shortest long-term negative effects. I worked with a child, an interesting case. She was a baby, a newborn baby, typically developing, and then at around 4 to 6 months of age, the mom started noticing as she was breastfeeding her, that there was nystagmus of her eyes. So her eyes were kind of jittering back and forth. What we know is, or what, she took her for a well baby check and said, gosh, she's not focusing on my face. Her eyes are dancing around. That just doesn't seem typical to me. And so having that nystagmus, it was a red flag to something neurological going on in her brain. And so they sent her to Rochester, Minnesota right away. They did a CT scan, MRI scan, and they found a very large brain tumor pressing on her optic nerve. And so it was causing that nystagmus. They went in and they surgically removed it, I believe at around 6 months of age. And they sent her home. They followed up with radiation. They sent her home. And they just wanted her to heal. They ordered early intervention. At that time, I was doing early intervention consults as part of my outpatient, and so I went in as an early intervention consult, and what I saw was decreased independence or balance with sitting. Like a 6-month-old should be, starting to sit. Bringing her hands together at midline. She wasn't doing that because she basically wasn't using the right side of her body. So there was that hemiparesis that was sort of taking effect. So, recommending activities such as sitting, doing some weight bearing on that affected upper extremity, bilateral hand activities, trying to get her to do patty cake and clap and hand over hand assist and some of those kinds of things. So she ended up healing. They ended up making some progress with just her healing and those sorts of things. They took her back to Rochester for a follow-up clinic, I believe, fairly soon after she was 6 months. I want to say it was just a few months later. And that tumor had regrown itself already after that huge traumatic surgery. So that everybody was just devastated. Because she was very young, and what did it mean now that this tumor had come back, and she still had the worst sutures in her head from them, because they had to cut open the entire skull to remove that tumor. So it was a very invasive surgery. So at that point, they decided not to do a surgery right away, but to kind of experiment with radiation and chemotherapy. And so when they started the chemotherapy, she became very, very, very sick. Chemotherapy just ruins everything because it just attacks everything in the body. So she was at high risk. Her immune system was compromised, so she was at high risk for developing other infections. So at that time, we recommended outpatient therapy. So then my hat changed from an early interventionist consult to an outpatient therapist. So we would go into the home because we didn't want to bring her to our clinic. We wanted her to stay in her home to protect her immune system. So we would wear a mask when we'd go into the house. We would douse ourselves in hand sanitizer, those sorts of things. Anything that we were taking into the home, we would wipe with Clorox wipes, those sorts of things. And again, we were looking at sitting. We were looking at weight bearing, bringing her hands together at midline for self-feeding, those kinds of things. Now, this was around, I believe, 8-9 months of age. And so starting those finger foods, those kinds of things were very challenging. She started to have a lot of sensory issues because when you think about her entire life, it was grabbing her hand, sticking her with a needle, and we still didn't know what her vision was at that point. She was still having the nystagmus, obviously because the tumor was still there. She was difficulty tracking. She couldn't really track things, those sorts of things. And so we were doing a lot of hand-over-hand assist with her, which she would immediately pull away and immediately become fussy. So again, very tactily sensitive because of the trauma that she faced from the needle sticks and the chemotherapy sticks and some of those kinds of things. Also just overall achiness from the chemotherapy and possibly even the radiation that she was undergoing as well. So natural development, we're looking at, okay, we should be giving her, we should be working on self-feeding, those kinds of things. And she was very sensitive to anything putting into her mouth. When she was home from Rochester, she would get oral doses of chemotherapy, which would make her very, very, very sick, like throwing up sick. So during those times and during those doses, she wouldn't keep any food down. And so it didn't take her long to kind of associate everything that was going in her mouth would come back up through her mouth. And so she became very defensive to the different textures in her mouth. and those sorts of things. So they actually ended up placing a G-tube so that they could get some nutrients in her. And as OT and speech therapy, we worked on sensory, we worked on trying to decrease oral defensiveness in her mouth and try to get her to progress to be able to eat. But again, we were working against that chemotherapy drug, so it was very, very challenging. As an outpatient therapist, you have to justify progress, right? And justify why you're seeing this child, continuing to see this child. And it was very hard because she would have chemotherapy dose and then the family would cancel for a couple weeks because she just was so ill and so weak. And fussy. And so, very limited progression. However, then when those chemotherapy doses would sort of wear off, therapies would go back into the home and we would work and we would make some progress. Then she would have chemotherapy and then she would regress. And so just documenting that, it was very clear that she was progressing, but when she would have a chemotherapy dose, she would regress. And so, we didn't have any trouble with insurance at that point. I know it's kind of a long story, but one that I still keep in contact with a family. It's 6 years later. She still has a brain tumor. They still go in. She's had multiple surgeries to sort of remove that brain tumor. The family has explained like the chemotherapy radiation as very experimental. And you may hear some of this with childhood cancers, is that it is so experimental. There's not a lot of research on it. So for her, they would try one chemotherapy drug. It didn't seem to decrease the mass of the tumor, and so they would try another one, and then they would try a combination of the two, and then they would try that for a while, and it looked like it was helping, and so then they would go in and remove what was left of the tumor, because basically the chemotherapy would make it less heavy. It would decrease the mass, and so then it wasn't as terrible of a surgery, or so they said. And then they would keep going with that chemotherapy, and then they would change, and it just is ongoing for this poor girl and her family. So I know when we started working with her, the doctors didn't give her very long to live, and now she is in the school system. She is getting services in the school. She does have very low vision, so her vision is affected. They're able to do some further teaching on that, and working collaboratively with the Ann Carlson Center and low vision specialists and those sorts of things for her. So at this poor family, I just, this is a case where it was hard to keep a positive attitude, hard to know how hard you push her, how hard you push the family when life expectancy wasn't well known. But to not give up hope, because it's 6 years later and she is using both sides of her body. So I like to think that therapy that we did do at such a young age was helpful and did increase that quality of life. So sorry for the long story, but anyways. Looking at lymphomas, lymphomas, again, you look at lymph, so the lymph system is affected. The spleen and lymph nodes are kind of a big portion of the lymph nodes, and so you have some sort of cancer that's affecting the spleen and lymph nodes. It's the third largest group of childhood cancers reported, and they have Hodgkin's disease or Hodgkin's lymphoma. Hodgkin's disease, I think, is still a term used, but it is sort of the outdated term. And then you have non-Hodgkin's lymphoma. And so we'll kind of talk about the different types of these. Unfortunately, the etiology is somewhat unknown. I have personally known people who have had that, who have had one of these types of cancers, and actually her mother and her were diagnosed at the same exact time. And so kind of interesting, there probably is a genetic component to it. Hodgkin's lymphoma or Hodgkin's disease looks at cells in the lymphatic system. Lymphatic system being composed of lymph vessels, lymph nodes, and specific organs, such as the spleen. And so those cells are growing abnormally. It can present as painless, but progressive enlarging of the lymph nodes, and it can first be found with swollen lymph nodes in the neck. So they may present with fever, nausea, night sweats, maybe a dry cough, maybe wheezing or trouble breathing or loss of breath, loss of appetite, maybe even sort of an itching kind of feeling, which could be associated with a fever rash, those kinds of things. And so, again, very, very similar to any childhood disease or illness, for that matter. The fatigue is what is quite persistent, as well as the weight loss. So there's unexplained weight loss that usually is 10% or more of the child's body weight, which is very significant. Especially for a child, 10% of a child's body weight is very, very significant. If you are working with a 50-pound child, and that 10% would be, 5 pounds, doesn't seem like much maybe for you or I, but for a child that size, it could be very significant. The symptoms usually last more than 2 weeks, or they're repetitive, and so they come and they go, they come and they go, and so that's where kind of the red flag of cancer sort of should come up. You're unlikely to see this before the age of 7, and then when you become older than the age of 7, the prevalence increases until about their mid-20s, and then it decreases again. Risk factors, so the etiology is kind of unknown, but the people between the ages of 15 and 40, so again higher than age 7, but 15 and 40, there's a higher risk factor. But then it also goes up to more than 55 years of age. And so this is where, there may be a family history, a brother, sister with the disease. They may have an increased risk of developing Hodgkin's lymphoma. And this is where, my friend was in her early 20s at the time. Her mom was older than 55. And again, they both were diagnosed at the same exact time. So it can be very interesting. Males are more likely to develop Hodgkin's lymphoma. Again, my friend and her mother are female. It really compromises the immune system. And so if they're already at compromise of an immune system, like HIV/AIDS, maybe they've had an organ transplant, maybe they are on meds to suppress the immune system for some reason, for like I'm thinking like JRA for an autoimmune disease, they're going to be at greater risk for Hodgkin's disease as well, or Hodgkin's lymphoma. Geography, ironically, it's least common. Hodgkin's lymphoma is least common in the Asian countries. However, the US, Canada, and Northern Europe have a higher prevalence. And ironically, it's more common in people with higher socioeconomic background than lower socioeconomic background. So that's sometimes a little bit different. The treatment depends on the extent of the cancer. They may do chemotherapy, radiation, they may do bone marrow transplants, they may do stem cell transplants. It's so experimental, again, with any type of pediatric cancer. And It just depends on the type and the extent, or the extent of the cancer. Complications, again, because of some of the chemotherapies, radiations, there may be sterility, there may be cardiovascular diseases, because of just the extent of cancer, and if it spreads, it could be a second type of cancer or another type of cancer. There may be vascular diseases. It may affect somebody's thyroid. Again, the thyroid being so close to sort of those lymph nodes in the neck. So again, it can be very, very complicated. Switching focus, non-Hodgkin's lymphoma is seen 3 times more likely in males than in females. So again, more likely in males. And it typically frequents children between the ages of 7 and 10 years of age. This one is caused by abnormal lymphocytes. So those lymphocytes in the blood continue to divide and grow uncontrollably, which causes crowding in the lymph nodes, which is going to result in swelling in the lymph nodes. Non-Hodgkin's lymphoma metastasizes more rapidly and becomes more disorganized, sort of unpredictable, a little more aggressive maybe, more than Hodgkin's lymphoma. Again, you have some of the same symptoms as Hodgkin's lymphoma, like fevers, night sweats, weight loss, abdominal pain, swelling, chest pain, extremely itchy skin. You may have difficulty breathing, or kind of that persistent cough as well. And so again, very similar to other childhood illnesses, very similar to other childhood cancers. The risk factors, again, people who have had organ transplants are more susceptible because of the immunosuppressive therapies, in which case then the body's unable to fight off certain illnesses. Other infections, such as HIV/AIDS, is going to affect the immune system. Infections with certain parasites, even parasites such as malaria, or that cause malaria. So there's that increased infection. People are more at risk for developing non-Hodgkin's lymphoma. There's speculation as far as chemical exposure, so the link between insect killer or weed killer, there's an increased chance of developing non-Hodgkin's lymphoma. As I've said, there's an increased risk of children between the ages of 7 and 10, but also as adults age in their 60s and older, there's a higher incidence of people where non-Hodgkin's lymphoma comes back in the older age as well. Symptom or treatment is very similar to that of Hodgkin's lymphoma, where chances are there's going to be a treatment of chemotherapy, radiation, and again, there's a lot of research being done on stem cell transplants and those sorts of things to affect and improve overall outcomes. Lymphoma prognosis, the first thing they do is decide on what stage cancer they're in. And so, are they stage 1 through 4? Again, with lymphoma, there's certain types, or there's a specific stage for that. Once the stage is determined, then they will decide if they're going to use chemotherapy and radiation, or what variety they're going to use, or combination they're going to use. Luckily, 80 to 90% of children with non-Hodgkin's lymphoma that are treated with a multiple drug combination of chemotherapy, as well as radiation, so that combination, do get a full remission. So 80 to 90% do get a full remission of non-Hodgkin's. Sarcomas. When you look at sarcomas, again, you're looking at osteosarcomas are more common. which are related to osteo, bone, oma, tumor. And so you're looking at tumors that are actually seen in the bone. More commonly, they're seen in teenagers, and they're typically found in the end of long bones, such as your humerus or your femurs. These rapidly spread to areas of the body, and they're resistant to radiation. And so here is where you may see an amputation, okay? And so then you may have a limb abnormality or prosthetic training, those sorts of things. And so since it does spread rapidly, they're going to amputate where they can. And to kind of prevent that from spreading, if it's already in their system, they're going to use a chemotherapy. Again, they may require extensive prosthetic training after surgery, which an OT may work hand in hand with a prosthetician. They may do ADL training, transfer training, those kinds of things with that prosthesis to help this individual move on with their life. Ewing sarcoma is also a type of bone tumor that's found in the bones of the trunk. So it may be in the ribs, it may also be in the long bones, but it also could be in the skull. The difference between osteosarcoma and Ewing sarcoma is it does respond well to radiation therapy, and so they may do some radiation for Ewing sarcoma. Both are seen in adolescents more commonly. And you think about kind of the growth spurts that are occurring in adolescence, it would make sense that, again, with cancer being abnormal cells, that we're seeing those tumors kind of at the growth plates or the end portions of these bones. Leukemia, the most common type of cancer in children, and it originates in the bone marrow. They do not know what causes leukemia in general. The first type of leukemia is called acute lymphoblastic leukemia, or ALL. This one is the most common type of cancer in children, and it occurs more often in boys. The diagnosis is typically made between 3 to 4 years of age, and again, your symptoms are going to include that of just a typical childhood virus. You may have irritable behavior, fussiness, fever, lack of appetite, those types of, again, very common types of illnesses. However, with ALL, these symptoms do not resolve. They make the diagnoses by doing a bone marrow sample and taking sort of a bone marrow biopsy. Now, I've heard from some people, I've heard from some kids that have said this is so very painful because they have to drill into a bone, and it can be very painful. And I don't know how they use... sometimes they put children under, sometimes they don't, for anesthesia. Sometimes it's just more local. And so I just remember hearing some people say that it was very painful. The second type of leukemia is acute myelogenous leukemia, or AML. Unfortunately, this one has a really poor diagnosis. The diagnosis, or prognosis, I'm sorry. The diagnosis is usually made in the teen years. The symptoms include fatigue, just a history of recurrent other types of infections like colds, flus, so just very sickly, a fever. One symptom that is different is spongy bleeding gums. And so for AML, spongy bleeding gums is actually the result of leukemia cells that are actually invading this part of the body and cause, again, kind of softer gums, which would indicate an increase in bleeding, those sorts of things. With kind of going back and comparing and contrasting Um, ALL, so acute lymphoblastic leukemia, again has a better prognosis. There's a cure rate of 60%, and the disease, children being disease free for 5 years. So a lot of times they'll do routine testing for children who are diagnosed with leukemia, and then after that 5 year mark they kind of say, okay, you're cured, you're less likely to have recurrent cancer. um, However, with AML, that prognosis is poor, and so they may go in and out of remission, and they may have, recurrent types of cancer, and they may have longer term effects of the chemotherapy, and actually death is more common from infections following chemotherapy. So what is OT's role in cancer? So, the OT's role in cancer, I've talked a little bit about sort of how that looked in with a child with a brain tumor, and how that impacted early intervention, right, or early intervention since she was between the ages of 0 and 3 years of age, how that was appropriate. Because of her hemiparesis, we just were working on facilitating those overall development skills, trying to increase active range of motion, trying to prevent muscle tone from, increasing that, trying to prevent her from getting spastic, basically. So to prevent that tight tone by doing weight-bearing techniques, by having her do bilateral hand activities, those sorts of things. We were trying to teach her how to eat, and use eating utensils, and trying to increase her overall activity tolerance and strength, so that she could be independent. For her, there was a big vision piece as well, because again, it was affecting her optic nerve, and so we really questioned what was she seeing, and so thinking about visual motor skills, how that would be impacted as well. Again, as an OT, I felt like that was such a huge question mark that would increase so many things or decide so many areas of her function that we did get a low vision specialist involved. Cognition. If there's a brain tumor that's pressing on that frontal lobe, chances are they're not going to have much insight into things, kind of like a head injury. So again, it just depends on the age of the child. It depends on what setting you're working in. I think of like a hospital. There's childhood oncology units, and just kind of the implications of self-esteem, coping, right? If they're losing their hair, how are they going to feel about themselves? If they're scared about losing their life, what are some leisure activities or leisure exploration, self-esteem, those kinds of things that you could do. What are they going to have to do at home, right? If they've had surgery, to remove a neuroblastoma, is there any adaptive equipment you can give them to help them be more independent with dressing? Are there any energy conservation techniques that you can teach them to help manage the fatigue, the nausea, those kinds of things? And so I think this is a very generic thing that you could do. or a very generic OT role in cancer, because again, looking at what you could do in a hospital setting, what you could do in outpatient, kind of going to fine motor, gross motor. Some of the kids I've worked with that have had recurrent chemotherapy, they complain of sensory loss in their fingertips as kind of a side effect of chemotherapy, and so their fine motor skills may be affected as well. So when I looked at maybe a frame of reference, it may be motor skills acquisition, especially for the little girl with the tumor, brain tumor. It may be related to scope at frame of reference, trying to be more holistic. I believe I did do a motor assessment looking at motor. I did do an evaluation that looked at self-care skills like the PD or interview questions, those kinds of things. Goniometer, range of motion testing, those kinds of things I've done with all types of kids that have experienced cancer as well. The role really is endless. Pediatric OTs, if you're looking at working in sort of a chronic illness or terminal illness type of setting, you're going to be working with kids who may die, and that is very hard. Not just cancers, but if you're looking at working with kids with terminal illnesses, AIDS and HIV, again, are two chronic care issues that can affect the pediatric population. I feel like recently there's been some positive research on HIV/AIDS for kiddos, and I haven't really followed up with that lately. I feel like there's been some advances in that area. Either way, there's going to be quality of life issues, whether you're dealing with cancer, whether you're dealing with HIV/AIDS. This is related to medications, or if they get sick, somebody who has AIDS or HIV, if they're having pneumonia, you have to weigh the issue of, do I want to go in there and work on activity tolerance when they're not feeling so well, or do I want to give them a day off? What's going to benefit their quality of life the best? As OTs, your personal and professional grief, you need to deal with this. You need to figure out how you're going to deal with this while you're working with the family. One of the families I've worked with, I think were very, they liked it when their therapists voiced compassion or sadness, which I think is kind of unique. Some parents I've worked with view us as a healthcare professional, and we're kind of the one that's supposed to give them hope. We're the one that is supposed to increase their child's quality of life, and so they don't want to see us expressing those emotional things and sadness, right? They want you to work with their children and be upbeat so that the child doesn't feel like there's anything wrong, or they don't feel hopeless. And so those are things that you really will have to sort of weigh out and get a feel for, and use that therapeutic use of self. There were times when I went home, especially working with that little girl with the brain tumor, where I went home and I really struggled. What is the bigger meaning of this? Why would, and there were spiritual things that were, why? Spiritual questions, why? And it was hard. It was hard, and I had to take that home, and I had to cope with that, and I had to go to work the next day with a smile on my face and try and face that. So it's challenging. Here's just a video of kind of a family story. I have, It seems like on my computer it's kind of fuzzy, but I really relate well to the family. It just a few of the experiences I've had, it sort of relates to this video. I thought it did a good job, and so I hope you enjoy it too. And that concludes my lecture on terminal illnesses. Not a very positive diagnoses, but certainly one where we can have an impact and we can have a difference in somebody's life. So thank you. If you have any questions or want any further clarification, please come let me know.